Good afternoon, colleagues. Dumelang bagaetsho, some of you are online. Molweni, Sanbonani, welcome to this inaugural lecture. It's a very special welcome to our a guest of honor, Professor Jackie. Jackie, I wanted to pronounce your surname in Setswana. Frankly speaking, when I saw it the first time, I thought you were a Motswana. It was Jackie Hoare. Because there are Botswanas, particularly in the northwest, far in the northwest, they would be, the Hoares would be there, but we will call them Hoare. But you are Jackie Hoare, Professor Jackie Hoare, and her family and friends. I want to thank the special people in Professor Hoare's life for sharing her with us at the University of Cape Town. She has worked very hard since her early years to develop her field of study and has built a solid reputation in her field of study with her impressive body of work. But an academic's excellence also depends on the support of loved ones, collaboration with friends. So tonight, as we celebrate Jackie, we are also celebrating the people around her, people who have shared the journey with her, because they've played an important role in her success. It is my pleasure to introduce you to my colleagues on the platform party this evening. I'm your host, of course, if you haven't figured out, I'm the Vice Chancellor. I'm normally taller than I am today. So don't worry, it's today's thing that I'm so short. I'm normally much bigger and much taller and much older. My name is Mamokgethi Phakeng, and I'm going to be inviting several people to come and talk here on the podium. I won't come back and forth to invite them. I'll only introduce the first person when I call him in, and everyone will follow from then on. Professor Dan Stein, the head of psychiatry and mental health, will introduce tonight's speaker. And tonight's speaker, I've already introduced her to you, Professor Jackie Hoare. And then we have Professor Swartz, who's Professor of Psychology at Stellenbosch University, and he will give the vote of thanks. We've got Associate Professor Liz Lange, who's our Deputy Vice Chancellor for Teaching and Learning. Thank you very much, Liz, for joining us. And on the platform party is also Professor Sue Harrison, our Deputy Vice Chancellor for Research and Internationalization. Thanks very much, Sue, for joining us. And Associate Professor Lionel Green-Thompson, Dean of the Faculty of Health Sciences. Lionel, we have taken over your inaugural lecture. It's now a VC's lecture. You have the whole executive almost here. But thank you for hosting us today here. The first formal university in the Western world opened its doors in the year 1088 in Bologna, Italy. Over the centuries since then, people have grown used to thinking of universities as places of tradition, as old stone buildings that house crusty academics who cling to established ideas and ways of doing things. Nothing could be further from the truth. One reason that the university as an institution has grown around the world over the last 933 years is because it is not static, but organic. Universities grow and change because of our academics, and the academics grow and change. They provide foundations for new academics to take that growth further with every new generation. University graduation is considered a rite of passage for young people who are about to enter into the working world. Academics have a rite of passage too. The inaugural lecture serves two important purposes. First, it commemorates the inaugural lecturer's appointment to full professorship, an accomplishment that can take many years of hard work, research, writing, teaching, and collaboration with colleagues around the world and within the professor's institution. It may even involve some sacrifice. Most of the time it does, especially when it's a woman. Sacrifice on the part of the academic as well as their loved ones who provide important support through the academic journey. So the inaugural lecture celebrates not only the professor's accomplishment, but the teamwork that led to this important promotion. The second purpose of the inaugural lecture is to provide a platform for the academic to present the research that they have built during their career, at least up to now. This also gives UCT the opportunity to showcase our excellent academic team and to offer a glimpse into a broad body of research. During inaugural lectures, we invite not only members of the university community, but also the general public to join us in this celebration. Because learning and research do not belong to the university alone. It's something that we want to share with the society around us. They are made possible because of the support of loved ones and other supporters, colleagues across the education and private business community through their funding, students, donors, government and media, to name a few. And that's why during this success, we invite everyone to join us. Universities provide a central place where all these participants come together and contribute to the academic journey. The inaugural lecture can serve a similar purpose. In a sense, the inaugural lecture is where the university unleashes our new professors to the public. It is the beginning of what we anticipate will be a long and distinguished career for Jackie today. This is in direct contrast to the tradition of many universities in the USA, which wait until an academic is about to retire and then invite them to deliver what they call a last lecture. That marks the end of the academic journey. I'm sure many of you who might have followed Professor Randy Pouch, who's a professor of, he was a professor of computer science who had pancreatic cancer and wrote the book, The Last Lecture, focusing on his journey with pancreatic cancer. Very interesting. I followed him online until he passed on in 2008. And then he ended up giving the last lecture and did lots of other interviews in a diaper. So he was standing there in the last lecture because he was medically boarded. He had an opportunity to say no, but he felt he should say yes. He wants to do the last lecture before he goes on medical boarding with time to his life. So universities in the US do that last lecture that marks the end of the academic journey. The general topic often in those last lectures in the US are described as, what wisdom would you try to impart to the world if you knew it was your last chance? That's what the US did. They asked someone as they live. Yeah. While we applaud the opportunity for professors to share their accumulated wisdom at the end of their careers, we believe new professors, such as Jackie, have wisdom to share with us today. So we in South Africa do an inaugural lecture to recognize the body of work that's done up to there, almost like saying to the community, this is how far I've gone, and this is where I'm going, let's go. Professor Hoare has focused her psychiatric career on saving patients who have been marginalized, not only by mental health needs, but also by diseases such as HIV/AIDS and COVID-19. Mental health is not just a side issue for these patients. The World Health Organization reports that depression is one of the leading causes of disability, that suicide is the second leading cause of death among people between the ages of 15 and 29 years, that people with severe mental health conditions are likely to die as much as 2 decades earlier than they should because of preventable physical conditions. Professor Hoare also provides essential support for the workers in the public health sector who treat these patients and work with their families. Academics like Professor Hoare provide lessons not only from a textbook or laboratory, but from that deeper place where medical professionals, patients, and their loved ones interact with and support each other. It is essential that we hear from the wisdom she has garnered so far in her early career. I'm so glad that we have this opportunity to do so today, face to face with some of you and all of those who are joining us online, and that we do not have to wait for decades to learn what this brave academic can teach us as she retires. She can tell us, she can teach us now, long before she retires. And at this point, I want to invite Professor Denstein to introduce Jackie to us. Thank you.
Vice Chancellor King, Dean Thompson, colleagues, friends, and family of Professor Hoare. It's an absolute pleasure and privilege to introduce Professor Jackie Hoare to you today. It's a wonderful opportunity to celebrate not only her, but also the field as a whole. And as Professor King was saying, mental health has really never been so important as it is today. Also, Dr. Patel and Dr. Ike, thank you for being here. It's a long time since we had such an occasion in the faculty in general, and in the Department of Psychiatry and Mental Health in particular. And we have a new VC and a new dean since then, and so a word or two about psychiatry, about consultation, liaison psychiatry, and neuropsychiatry in particular, and Jackie's contributions to these two subspecialties. So I'm going to talk a little bit about knowledge. It's every month or so I get a question about entering our MMed psych program, and it's amazing to me that people are not always aware that you need to do an MBCHB to do psychiatry. So I'm going to come back to this area of the knowledge of medicine, and particularly Jackie's knowledge of medicine and of psychiatry. Now you may argue that medicine is the study of the body, while psychiatry is the study of the mind. Medicine's about real and important diseases, while psychiatry, the people out there, my boss, my partner, my kid, you know, just on another planet. And while that's tricky for me, that's not exactly a disease. This view represents partly a lack of knowledge, but also an attitude. So I'm going to come back to attitudes and Professor Hoare's attitudes in particular. And then in this faculty, we talk about knowledge, attitudes, and practices. So how do you use your knowledge and your facts, your attitudes and your values to impact communities? Psychiatry spans different subspecialties ranging from psychopharmacology through to public mental health, and these have different practices, different interactions with communities, if you like. And so neuropsychiatry and Cl Psychiatry then represent different sets of practices, and I'll come back to talk about Professor Hoare's practices. So another thing about psychiatry is we believe in the history, in the importance of a good, thorough history. How did it all begin, you may ask yourselves. So Jackie's dad was a headmaster, and knowledge was an important value in the family. Jackie's mom sadly died while she was in medical school, but Jackie inherited some of her gregariousness. Now, a very important aspect of the home was an emphasis on playfulness, on games, and on humor. So it turns out that Jackie's dad was not only the local maths and science teacher, but he also put on school plays, and he also introduced Uitenhage to Lord of the Rings and to Dungeons and Dragons. And then finally, he was also a man who believed in getting things done. So he was a gentle soul who went on teaching long past his retirement, because there was no one else in Uitenhage that could. So in terms of her very advanced knowledge, in terms of her playful attitudes, and in terms of her useful practices, for all of this began when Jackie was young. After high school, Jackie began her MBCHB at UCT. I won't go through the knowledge obtained through the curriculum. That's a matter of public record. But what about the attitudes? What was she like at that time, privately? So to earn money, Jackie did aerobics in the residencies and taught classes. She also did spinning at the local gym. Surfing, dancing, running have all given Jackie joy. And so let us imagine the young Jackie at medical school, only a little beyond adolescence herself, grinning as she went about these classes. Her close interactions with adolescents and her managing life with grit and with a grin are themes we'll keep coming back to. So Jackie then decided to do a specialization at the Maudsley rotation in the UK, very prestigious place, and over the next 6 or 7 years, to use her own life, she became an adult, taking on the responsibility of patients herself and having her own family with Doug, an obstetrician and gynecologist, a triathlete and a fellow practitioner of the art of grit and grin. And then Arwen was born. And so to Doug and Arwen, I would just say, thank you so much for being here today. I know it's a particularly difficult time for you, and the grit and grin is on full display. So England provided very important growth opportunities, but Africa called and the family returned home. South Africa doesn't see the UK training, even at the Maudsley, as quite up to scratch. So we had Jackie do an extra year at the University of Cape Town. And of course, her knowledge shone through. At that time, Professor John Joska was getting neuropsychiatry off the ground. It was time to train the first subspecialist in the area, and Jackie was an ideal candidate. What is neuropsychiatry? So it turns out that the brain is intimately connected to the rest of the body. Who knew? And that our brain minds are key for our thoughts and feelings. So let's say you have Parkinson's disease, there are changes in your neurotransmitters, you might get depressed, and you might need treatment. Another example is people with HIV, where the virus enters the brain, there are changes in cognition. So such patients might see a neuropsychiatrist, that is a psychiatrist with good understanding of neurology, or they might see a behavioral neurologist, a neurologist with good understanding of psychiatry. Either way, Jackie was soon the first person to train in either of these subspecialties in the African continent, and early on the focus of her master's and her PhD was adolescents with HIV, the beginning of a long-standing interest. So a quick update on neuropsychiatry. Today, UCT and John and Jackie's HIV mental health unit lead the continent in this area, with key contributions to teaching, research, and services. The graduate of the MPhil are national, international leaders. In fact, Jackie applied for specialist registration as a neuropsychiatrist in the United Kingdom. Based on her UC training, she was the first person to be recognized as a subspecialist in neuropsychiatry in the UK. So I'm not sure if all of us would call this decolonization, but I think we can agree to call it remarkable. Back to her career. At the same time that John was building neuropsychiatry, Bhavi Vittalingam was building Cl Psychiatry and left the services. Jackie was an obvious candidate. So you may ask, what is Cl Psychiatry? Well, this brain-body connection leads to enormous complexities in the hospital. There are people that present here with paralysis, but no neurological lesion. There are people that present here with an obvious cancer, but want to go home immediately. So when clinicians of Groote Schuur, and say there's no cancer, so when clinicians of Groote Schuur face such a patient, and very often they will call in Dr. Ike sitting over there, but they'll also call in the Cl psychiatrist. So a Cl psychiatrist has to understand the body fully. For example, COVID-19, which Professor Hoare will talk about in detail later, they might have to assist with managing the delirium of such patients, but they also have to understand the mind and human relationships. So a particularly powerful intervention in healthcare is the clinician-client relationship. So again, during COVID-19, key issues are the grief of families, the burnout of staff, and this again is where the Cl psychiatrist will be key. So to put it differently, as Professor Hoare leads Cl psychiatry, it involves particular knowledge, particular attitudes, and particular practices. So in terms of knowledge, Cl psychiatry covers the breadth of healthcare. And during COVID-19, Jackie was in the ward, not only adjusting airflow and writing medication scripts, but at the same time supporting patients and staff psychologically. She's co-authored or authored a wide range of papers in neuropsychology, pharmacotherapy, brain imaging, epigenetics, you name it, Jackie has written about it. So it's also partly about particular attitudes, and in particular, I would say, connection. So her ward rounds are absolutely legendary for the way in which the whole multidisciplinary team connects, thinking together, laughing together. If you ask Professor Ntusi of medicine, he'll say that Jackie's role in medicine was, she is one of us. And outside, she was being photographed with medicine. With adolescents, Jackie has a magical way of connecting, perhaps around her interest in fantasy or perhaps around a recent fad. So she has an ability to connect to everyone, to laugh with them, and to help them see another side of things. So you name it, Jackie has connected with it. Now, It's also about particular practices, and I'd say it's about practices that make a difference in the lives of patients and clinicians in a setting like Groote Schuur. So I asked a few clinicians how they see Jackie, and the term Professor Fix-It came up. So Jackie's practices involve problem solving, they involve addressing matters practically, getting on with things and moving forwards. So you name it, Jackie can fix it. So these sorts of knowledge, attitudes, and practices are also useful, it turns out, outside of work. Once you connect, say, with horses, anything is possible. Jackie has a Western Cape colours in horse riding, and Arwen has represented Western Cape since she was age 9, and she's got more than 10 South African horse riding championships. Fixing animals is also possible. You can do that with either meds or therapy. There's an orangutan. Jackie diagnosed the orangutan with postpartum depression and gave meds. Got better. There's the chicken with attachment issues that Jackie discovered and sat for hours in the chicken coop holding the bird in her arms until the behavior was improved. So I gave you a quick update on the division of neuropsychiatry. Let me give you a quick one on the division of CL. Teaching-wise, we now have several people who've done the CL MPhil with Jackie. It's registered as subspecialty. One of our registrar posts is dedicated to CL. And Professor Hoare is the person to train within the continent, in good part because of the way she connects with people. We have Professor Lowe in the audience, who's from another institution, equally good, but who trained with Jackie. Second, research. The division has an incredible 5 NIH grants on the go. And to put this in the context for our audience, this is more than some whole departments. She's a world authority on adolescent HIV, plenaries, talks at key meetings like AIDS and CROI, and a leadership role on key international boards. And again, it's about the connection. So a mentee who's in the audience wrote to me, her kindness knows no bounds. Third, the services. So under Jackie's leadership, there's now massive CL services at Groote Schuur Hospital with work across all of the departments. That's cancer, women's mental health, adolescents, etc., etc., etc. She's a passionate advocate for her patients, and recently a psychologist was hired in her division to address staff wellness. At every annual operational planning meeting we have, there's someone who thanks Jackie and Louise Frankel, her partner in the service, and I regularly get emails saying thank you to her for visiting Department X, for helping patient Y, or for assisting staff member Z. So my apologies to those I asked for anecdotes for this introduction. There were so many of them, I couldn't possibly include them all. Now, given that Groote Schuur Hospital sees psychiatry through the prism of CL Psychiatry, the teaching, research, the service, and the knowledge, attitudes, and practices that they embody has really changed the perception of our field at Groote Schuur. So Jackie, on behalf of Groote Schuur Hospital, on behalf of our department and the members of your division, I want to sincerely thank you for these contributions. So this evening is one of celebration, but there are also registrars here. And many jokes directed towards psychiatrists are about how can I ask this very odd, eccentric person for advice when their own lives are so clearly upside down? This refers to me, not to Jackie, right? So psychiatry's approach to this is to take that criticism on the chin. We are absolutely as human as the next person. I want to mention some of the all too human aspects of Jackie's CV, really as encouragement to junior colleagues that you too can do this. So there's that first conversation about doing the MPhil when there's no formal hospital senior reg posts. Dr. Lowe and I also had that. There's the cut in salary, the lack of job security, the being a human guinea pig. And so, even the incredibly brave Professor Hoare did have some trepidation at that point. So those of you considering studying in our department, please do so. Part of life is about showing up, no matter how stressful it is. Second, there's the first time you get a manuscript back from Dan. It's just red ink all over the place. And so for old time's sake, Jackie, I looked at draft 6 of your escitalopram HIV paper. There's still red ink, and he's changed his goddamn mind again. So the way forwards, I say, it's often about finding tenacity, about grinning, the human in the situation, those wanting to write, it's a horrible experience. Please give it a bash. There are those occasions when you apply for NIH funding and the number of forms you have to fill in is overwhelming. So you send Doug and you send Arwen up the mountain for a hike, despite not having seen them for weeks because of for COVID. You get the grant in, but there's not enough funding to do the work. No option but to keep going with grit and with grin. So those considering a career in academia, it's a struggle all the way, but think also what you can achieve. And indeed, in summary, as I close, this ad hominem promotion represents a massive achievement in knowledge, in attitudes, and in practices. So first, Prof. Hoare's ad hominem promotion represents a massive contribution to knowledge and to facts. This has been in both neuropsychiatry and Cl Psychiatry, itself a most remarkable point. And aspects of this contribution range from brain imaging through to psychotherapy, and it's represented by publications and grants at the absolutely highest level. Second, what I really hope to convey to you tonight is a massive contribution to attitudes and to values. And aspects of these include a tremendous work ethic and dedication to service, an outstanding ability to work with colleagues and with teams, and an ability to connect with others through warmth and through humor. And third, it's about practice. It's about engaging with people and with communities. And aspects of this include problem solving, finding a way forwards for staff and for patients, even at the most difficult times in their lives. If the patient's families can't visit during COVID-19, well, let's get them on the phone. Let's do what we have to do to make things better. So it's this kind of knowledge, attitudes, and practices that has characterized Jackie and her team's responsiveness to adolescent HIV and to COVID-19. It's this kind of knowledge, attitudes, and practices that makes Jackie a professor in the Department of Psychiatry and Mental Health at the University of Cape Town, Vice Chancellor and the Vice Chancellery, Dean and the Deanery, hospital managers, colleagues, and friends. It's been an absolute pleasure and privilege to introduce to you Professor Hoare and her work on the wonderful occasion of her inaugural address as Professor and Head of our Division of Consultation Liaison Psychiatry. Over to you.
To VC Pakeng, thank you so much for the warm introduction and welcome. Much appreciated, and thank you, Dan, for your kind words. And welcome to everybody who is here. It means so much to me, and to all of those who are joining in online via the live broadcast. So my profession is in the business of stories. So I will begin by telling a story. It's not an unusual story. These are young people's lives. This is a story of AB. He's a 15-year-old adolescent living with perinatally acquired HIV and diagnosed with epilepsy at the age of 9 years. He was seen by neurology at Hoare Hospital for poorly controlled temporal lobe epilepsy, now improved with the addition of lamotrigine to his valproate. Neurology, in turn, referred him to our team and our G26 adolescent clinic due to concerns around behavioral problems as well as cognitive changes. He was deemed by school authorities as dangerous to other students and removed from school pending psychiatric review. On assessment, I was confronted with a shy and withdrawn adolescent who had not only internalized the stigma of living with two chronic illnesses, namely HIV and epilepsy, but also that he was bad, undesirable, and discardable. There was no current evidence of mental illness or behavioral issues. These had all resolved with the treatment of his epilepsy. What was needed for him through therapy was to be able to internalize a different narrative of himself from the current one. Low self-esteem and internalized stigma, particularly in HIV, drives depression. And depression, in turn, drives poorer outcomes in both epilepsy and HIV. He also needed to return to school, something that we are frequently faced with at Contextual in terms of supporting our adolescents living with chronic illness. He requires multidisciplinary, integrated care. He needs Janine's neurology team. He needs Rudzani's pediatric ID team, and he needs our team, Consultation Liaison Psychiatry. He also needed our magnificent Contextual school headmistress, Rosetto Cupido, who is an absolute whiz at getting chronically ill kids back to school. He needs Contextual Hospital. Many of our Contextual patients have complex illnesses with a combination of physical, psychological, and social needs, of which may require help. Liaison Psychiatry, sometimes called psychological medicine or psychosomatic medicine, is one such profession. Clinicians trained in Liaison Psychiatry provide mental health care in physical health care settings. We have expertise in the assessment and treatment of mental illness when it occurs in patients with physical illness, particularly in the most complex cases. Patients with multiple needs often find it difficult to get effective help because they have separate mental, physical, and social care needs delivered by separate professionals working in separate spaces. The result is that care may be uncoordinated, inefficient, and patients may fall through the gaps in services. Providing good integrated care requires that professionals work together in unified ways. This lecture focuses on the integration of mental and physical health care, emphasizing the essential role of liaison psychiatry in the provision of comprehensive care, putting mental health in the front line. Integrated physical and mental health care should be provided in a way that enables patients to access the right care at the right time and in the right place. The way we think and feel affects us physically and vice versa. There is no such thing as completely physical illness or completely mental illness, nor do we exist separately from the world around us. Our social situations, such as our home, our jobs, and our stresses we find ourselves under, affect both our body and our mind, and we in turn affect the world around us. Mental illness is much more common in those with physical illness. Compared to the general population, people with illnesses such as diabetes or heart disease are twice as likely to have mental illness. The rate is even higher in some other chronic conditions such as chronic lung disease and in patients with more than one physical illness. And of course, depression and long-term illness interact. The pain and impact of a physical illness on someone's life can cause depression or make it worse. In turn, depression may worsen the pain, distress, and disability associated with physical illness. Someone with both a chronic condition and depression can struggle to be adherent to their treatment and to follow advice for healthy living. Having both a physical and a mental illness delays recovery from both and reduces life expectancy. When someone with a long-term condition has mental illness, the cost of their physical illness increases. For example, patients with depression and chronic lung disease have longer hospital stays. Also, the cost of treating diabetes is 4 times higher for those who are depressed compared to those who are not. The implications for our 15-year-old AB living with both HIV and epilepsy is that we need good scientific data to support and to understand the link between HIV, the brain, and mental illness. And we also need evidence-based programs to support him to reach his full potential. Central nervous system disease and mental health problems persist in youth living with HIV despite antiretroviral therapy and viral suppression, contributing to a significant decline in functioning. Youth living with HIV on antiretroviral therapy in South Africa have a prevalence of neurocognitive disorders of around 50% and significant alterations in their brain morphology. Our team was the first to describe a spectrum of neurocognitive disorders in adolescents living with HIV and to validate a screening tool for its detection. MRI has shown us that myelinogenesis continues from childhood and that the brain's neurocircuitry remains structurally and functionally vulnerable in youth. Findings from our own studies also suggest that HIV may exacerbate developmental imbalances between the limbic system and prefrontal cortex, leading to increased reward-seeking behaviors in youth living with HIV, which in turn may further negatively impact their outcomes. Our findings suggest that significant brain disruption in youth living with HIV, despite intact CD4 cell counts, include brain atrophy, morphometric changes, functional changes, and white matter damage. In contrast to adults, in whom early antiretroviral therapy appears to reduce or even stop volumetric loss, data from our longitudinal study in youth living with HIV with sustained viral suppression shows significant regional brain changes at follow-up compared to baseline in youth living with HIV versus healthy controls. Moreover, they have increasing prevalence of neurocognitive disorders, and these neurocognitive disorders are associated with decreasing brain gray and white matter volumes and increasing brain diffusion, which is a marker of inflammation. In addition, peripheral immune markers correlate with impaired cognitive function and brain inflammation or mean diffusion. Our functional MRI studies have shown that youth living with HIV have decreased activation in key areas while doing a maintenance working memory task, as well as inhibitory behavioral responses. At a mean age of 13 years, self-reported alcohol use has increased to 21% in youth living with HIV. We have also observed a synergistic effect of HIV infection and substance use on brain morphology. In addition, youth living with HIV who use alcohol have significantly more behavioral problems and poor self-esteem. Cognitive functions are also more impaired in those living with HIV and using alcohol versus HIV alone. We have also found that HIV is associated with biologically older blood according to measures of epigenetic age acceleration. Epigenetic age acceleration is also correlated with impaired cognitive function and associated with alterations in brain microstructure. Youth living with HIV have higher rates of depression compared to healthy controls, as well as poor self-concept or self-esteem and difficulties with motivation. Together, these findings point to an aberrant neurodevelopmental trajectory among youth living with HIV, with cognitive, mental health, and increasing substance use challenges. Despite well-established increased risk of depression and anxiety in people living with HIV, finding from our team's recent systematic review are that current prevalence remains high, with studies reporting up to 60% of people living with HIV having mental health symptoms. Depressive symptoms are associated with subsequent viral non-suppression through its association with self-efficacy and ART adherence. There is evidence that depression and anxiety and stressful life events can negatively impact HIV disease progression, including decreases in CD4 counts and increases in viral load, and increase the risk for clinical decline and mortality. Despite the significant challenges that depression and anxiety present to successful management of HIV and outcomes, there are many mental health treatments that work and can improve outcomes of people living with HIV. However, there are limited studies investigating the integration of mental health care in people living with HIV. Improving social networks, support, and adherence for youth is key to improving their chronic health outcomes. Family communication, resilience-orientated family interventions, adherence incentives, and peer support interventions have all been explored by our unit. Peer support groups can play a significant role in helping adolescents cope with chronic illness and open up channels of communication to support the transition towards successful management of chronic illness and improve the quality of their daily lives. To this end, we, Rebecca Scher, Bianca Davidson, Michelle Carrahill, and myself, decided to introduce and test an innovative twist to the peer support idea, that of mixing adolescents with different conditions in a single group. While there were initial worries, for example, the potential of stigma against adolescents living with HIV, the results have proved that the mixed group, called Better Together, has been amazingly successful and welcoming for adolescents across the board. For too long, youth living with HIV have been managed in silos. In our attempt to protect them from stigma, have we, the clinicians, unknowingly reinforced the stigma by managing them separately from all other children? In fact, many adolescents living with HIV who have joined Better Together have experienced a significant reduction in internalized HIV stigma by socializing with adolescents with other chronic health conditions. The purpose of the program, which has been running at Hoare since August 2017, is to help adolescents with a range of chronic conditions in the following ways: to enhance social networks, to improve perceived levels of psychosocial support, to develop a sense of belonging, to create a safe space where all members have some kind of chronic illness, to foster a sense of shared experience despite their differences, to enhance the ability to express empathy, all of the above to contribute to better chronic illness management. Better Together provides a facilitated group open to all adolescents who seek care at Hoare Hospital. The regularity of the group, which is held same time, same place, has become a really important safe space for adolescents to access when they need support, when they feel alone, or if they just want to socialize with peers. Topics addressed not only relate to dealing with a chronic illness, but to general health, development, and mental health issues. Despite having a chronic condition, these adolescents have similar needs and psychosocial burdens to their non-chronically ill peers. One of the important aspects of the group is the role of our trained peer mentors, who themselves are adolescents living with a chronic condition. These dedicated peer mentors co-facilitate weekly groups and serve within their own clinics as role models, Hoare Hospital navigators, and confidants. This model has now been manualized and funded by One-to-One Children's Fund and Vive Healthcare. We conducted a qualitative study to explore the peer support in G26 and Better Together. The findings of this study highlight the positive perspectives of both adolescents living with HIV and their caregivers regarding the role of peer support groups in both psychosocial aspects as well as in ART adherence. I will share some of the quotes from the adolescents and caregivers from this study. I would say that those people motivate me and inspire me to take my treatment. In short, we help each other. 17-year-old adolescent. Because they know that we have this thing. They are not shocked. They react properly. 12-year-old adolescent. Even if you have your own secrets, you talk about them there. They remain there. I feel free. 16-year-old adolescent. Wow, it's nice there. They really care about me. 14-year-old adolescent. One caregiver reported that support groups have a positive impact because they encourage and they show them that there is still life out there, you see. It is not the end of the world. It is not a death sentence, and it is not the end of your life. You still have a life, and you can still have a future they want to see. I just need a moment to have something to drink. If I had given this talk 2 years ago, it may have ended here. But I might also have had a harder time than I do today explaining to you that thoughts, feelings, and emotions are connected with the body, with illness in general, and with society as a whole. The COVID-19 pandemic has set off a global mental health crisis with unprecedented numbers of individuals meeting criteria for depression, anxiety, and other mental health disorders in response to the intense stresses of living through the pandemic. Every person in this room, whether you have had COVID-19 or not, knows from the inside what it feels like to live in a pandemic. We have been anxious, we have been afraid, and at times it has been difficult to think. But what does this mean for our patients admitted with COVID-19 pneumonia? And what does this mean for our healthcare workers? There are members of the COVID team in this lecture theatre. Graham, Ivan, Mark, Jenna, Greg, and more of you listening via the live broadcast. I do feel the weight of the responsibility of talking about something that we have all shared, and I hope that my words honor you and our patients. The co-occurrence of mental health symptoms in patients treated for COVID pneumonia is common, with studies reporting more than 60% experiencing significant fear and anxiety. Other studies have reported PTSD symptoms and delirium being very common, approximately 80%. Our experience in our high-flow nasal oxygen wards, high care units, and ICUs mirror these observations. My role was to provide support and a sense of safety for patients admitted in an extremely traumatic environment. In part, this was to manage the acute situation, but also to try and mitigate the risk of developing PTSD post-discharge. Early on, we recognized the link between panic and fear and worsening symptoms of COVID pneumonia. I aim to use here and now interventions that were quick and effective to manage fear, anxiety, and distress. Most of the time, I was able to use psychological first aid and borrowed from a variety of therapies such as mindfulness, CBT, problem solving, and motivational interviewing. However, if our patients were not contained using these techniques, or if the symptoms were particularly severe, I used pharmacological methods. Fear and anxiety are pervasive in COVID-19 high care environments, described by our patients as terrifying, but we could see this on their faces, particularly in patients who have never been admitted to hospital before or experiencing illness and vulnerability for the first time in their lives, such as young people who've never had to conceptualize their own mortality before. Our patients witnessed many deaths and intubations. They were also hyper aware of what was happening around them because they were all being treated for the same condition. Nothing feels quite like our COVID high flow wards. You can feel the shift in the energy as you enter. The beeping of many machines, the sound of oxygen flowing at high speed, and the breathlessness of our patients. This is the sound of COVID-19. Everything is fast, and seconds, not minutes, matter. Fear and anxiety not only impact respiratory function, but also decision-making capacity. Many of our patients declined intubation and ICU treatment, even when it was desperately needed due to fear. My role was to listen and to allow those fears and concerns to be expressed safely, and to support and facilitate an improvement in capacity, and then go on to consent for intubation and ICU admission. I was also present during many of the intubations for those patients who were overwhelmed or requested me to be there, and this was particularly common in young people and in pregnant women who not only needed intubation and ICU admission, but prior to admission to ICU would also need a cesarean section and were faced with the terrible reality that they may never meet their babies. I used a similar approach in patients wanting to discharge against medical advice, despite being critically ill and needing high flow oxygen. Liaison psychiatrists are ideally placed to manage these difficult situations, most common in patients who rejected science and those who had a tendency towards conspiracy theories. It was also important to facilitate for the team a space to think through complex ethical and moral dilemmas, issues at risk of causing moral injury, a trauma that doctors are particularly vulnerable to. We needed to hear the stories of how our patients experienced this new infectious disease and learn from them and bear witness to their journey. This is the fundamental art of medicine. It is the understanding of the individual from who we care that provides us with meaning and purpose. And it is in connecting with their personal experiences that improves our clinical care. These connections bring us incredible joy when our patients survive and go on to thrive. The Hoare COVID team has saved many, many lives. However, making these connections with our COVID patients also takes an enormous amount of courage, as we have suffered innumerable losses. It is well established that in medical socialization, there is pressure to become an expert, the demand to fix difficult situations and to remain in control. Vulnerability and anxiety may be experienced as humiliating, shameful, and something to be hidden. It seemed to me that in holding others' pain, our COVID team was neglecting to address their own. They needed emotional support. My colleagues were experiencing the unimaginable and the unspeakable. However, traumatized groups isolate themselves and are difficult to access. The only way in which they could begin to speak of what they were going through was through me having an embodied experience of what they had experienced. I had to become a part of the COVID team. I had to deal with the same trauma and anxieties myself. I had to bear witness to the same suffering and deaths that the team were. In addition to me becoming a part of the COVID team, Louise Frankel and I ran a weekly support group. We have written about our and the team's experience, and this has been published in the Lancet Psychiatry in October. We came to see that the many sets of tools, such as resilience training, which have been developed to help medical personnel cope, though they have their place, may be experienced as positioning our colleagues as incompetent or lacking, that they need to fix something in themselves, when in fact the primary issue is not clinicians not coping, but a situation which is impossible and challenging to manage. Once the impossibility of our task was recognized and experienced, then it seemed to us there was space to think. The function of the groups was to make a space where the team could feel safe and connected and not alone. The aim was not to provide a set of coping techniques, but rather to put these experiences into words and thereby address the isolation and stigma that trauma inherently brings. We understand from the literature that trauma can isolate one from those who have not been through the same experience, while at the same time binding those together who have. Our description of a collegial-based intervention argues for the importance of integrating liaison psychiatry within COVID-19 frontline teams, thereby facilitating a basis of trust, shared experiences, which shifts the model of supporting our colleagues in a traditional group therapy model to that of a collegial peer support space. We needed a safe space to acknowledge that we were not all okay, that the masks we wore for protection also revealed our vulnerabilities, that the protective equipment in hospitals do not protect us from the grief and loss that we were facing daily. As we let ourselves be vulnerable with each other, we saw the true face of our pain. It was not stress. We were stressed, but it was not stress. We needed the right words to define our experience. We needed the right words to have the conversations that mattered and to access the care that was meaningful and helpful. It was grief. It was trauma. We were sad and mourning innumerable losses. At times it was overwhelming. Without spaces to process, grief festers and eats away at our mental health. How do we hold grace for ourselves, dare to be vulnerable, and allow ourselves to feel, when doing so opens the door to our own grief? How do we allow room for emotional processing when we have learned to numb in order to function. We needed to process our pain in order to heal in the slow and very uneven way that grief heals. The trauma we felt was real. Our collective grief and our collective trauma demanded collective healing. We needed to honor our shared humanity and find commonality amongst our differences. We need to deconstruct the cultural medical narrative that vulnerability is weakness. We needed to learn a different way of functioning, one where grief is acknowledged and even actively processed while still going about our work. If we allow the reality of grief to exist, we can focus on helping ourselves and one another survive. In the throes of this crisis, our team supported each other. During the waves, we were driven by the intensity of the work, fueled by a common purpose. We were trying to minimize suffering and to save lives. We adapted to survive. The acuity of the work focused our minds and our bodies. However, there are between-wave consequences. Between the waves can bring different experiences. Difficulties in returning to normal life. We have felt separated, isolated, and disconnected from the world around us. The world outside of these wards can feel slow and lacking in meaning. While this may be a cognitive distortion and we are able to recognize it as such, it can't always stop the feeling. Our lives are full of meaning, and our work outside of COVID full of purpose. But the exposure to the trauma of the COVID wards changed us. We found it hard to connect and explain to others what we were feeling. Trauma can isolate those from those who have not been through the same experience while binding together those who have. The feelings of otherness, feeling numb, disconnection are barriers to reintegration between the waves. Difficulties with low mood, irritability, tiredness, sleep, eating, attention, and concentration have been experienced by many. We have tried to manage these symptoms by staying connected with each other and talking about it. Normalizing these experiences is important to minimize the self-stigmatization and isolation, as these are all understandable reactions to traumatic experiences. After all, what I am describing should be familiar to all of you. It has been described before in soldiers returning home from deployment. As we yearn for better days and brace ourselves for the fourth wave, we will take advantage of these opportunities for self-reflection. We have hoped for more time to heal some of our wounds, but it seems that that is running out. Liaison Psychiatry shows us that we live in a complex and challenging world. For us to be good at our work means that we must reject false distinctions. For example, we cannot focus on the mind and exclude the body, or focus on the body and exclude mental health. We must not try to choose between good health care and good mental health care. They are the same thing. My particular skills are as a clinician scientist, but I cannot, in doing this work, focus on just the individual, the person in front of me, or the lab report in the file. I have to think, often with my patient, about how this all fits into their world. I'm a doctor first, but I have to be an advocate and support struggles for mental health, led by people with skills that I do not have. And I include here other healthcare workers, patient advocates, and activists for social justice and climate change. Health, including brain health, is ultimately a question of social, political, and indeed planetary justice. Another key binary is that between us as clinicians and our patients. Liaison Psychiatry is not alone in teaching us that we are all vulnerable, that we all have care needs. It is in this common humanity, which is in our brains, our bodies, and our lives, that should form the basis of good health care. The challenges are enormous, and none of us can do this on our own. My work is a very small contribution to the joining of hands and working together for health. I have so many to acknowledge and to thank. You are family, you are friends, colleagues, colleagues who've become friends, and colleagues who've become friends who've become family. You are my leaders, my mentors, my inspiration, my home, and my joy. You are a magnificent woman, Louise. I've had the privilege of walking beside you.
Wow. I can't be equal to that, Jackie. I'm going to give it a go, and I'm very pleased that I actually, for once in my life, have something written down, because I'm overcome, and I'm not the only one. You could hear a pin drop here. So, Madam Vice Chancellor, Deputy Vice Chancellors, Mr. Dean and Vice Deans, Professor Stein, honoured guests and friends, but most of all, Professor Hoare. It's an absolute honour, privilege and joy for me to give this vote of thanks. Thank you, Jackie, for asking me to do this. It means a huge amount to me. People who don't know me, I'm a UCT alumnus. I gave my own inaugural lecture at UCT about a quarter of a century ago. People these days seem to look a little bit younger. The buildings are much nicer, but it's lovely to be in a place I can still call home. But the particular treat and the task, which is not such an easy one in some ways, is thanking Jackie on behalf of us all. I just want to start with a little bit of kind of context, because it's been quite a week or 10 days for South African healthcare and South African science. We should be proud and grateful, as should be the whole world, to our scientists for identifying the latest variant of COVID. and choosing correctly to communicate this information rapidly. But this has also been the week of global action based not on science. It's been a week of closing the door to our country, to our continent, quite clearly after the horse. Sorry, Jackie, I hope you noticed there's a horse reference here. Closing the door after the horse has bolted and reinscribing painfully, I'm sure for all of us, and with grave economic and personal consequences, dangerous colonialist assumptions about Africa, about contagion, about dirt and pollution. So here we are, a wonderful week in which our country leads the world in science and science communication, and a terrible week in which again we bear the brunt of the long and ongoing tale of dangerous colonial and non-evidence-based views. As Africa has helped in all likelihood to make the world more healthy, many in the world have helped to make Africans more sick. These events and the happenstance of Jackie's talking here at this particular moment help us, I think, to understand what her unique contribution is to science and to healthcare. In my view, we desperately need 4 things for the best science and healthcare in our country, and I'll go through them briefly. Firstly, we need global and local equality and inclusion. We know that these are key to the health and mental health of everybody. Though healthcare practitioners, scientists cannot achieve global and local equity and inclusion alone, we're an important part, but a small part, of a much bigger puzzle. The issues which Jackie has raised today and the location of her work in practical, everyday stories, and she started with just such a story and continued with others, are important not only in demonstrating the consequences of inequality, but also in providing to us the impetus to work harder to achieve important health and mental health related contextual goals. Secondly, we need good science in its most traditional sense. Professor Hoare has shown us the key importance of understanding the brain in relation to HIV and human development. This is cutting-edge science and published in top journals, as you've seen, in the field globally, making Professor Hoare a national scientific treasure. But this science in itself is not enough in terms of what we need, and this brings me to the third requirement. We need good contextual care, and we need it in 2 ways. The first way in which we need this care is that we need care which is appropriate to the context of our patients. We need to bridge the gulf locally between empirically supported treatments and true evidence-based practice, grounded in the realities of our health system and in the realities of our patients' lives. Jackie Hoare is a shining example of somebody who has chosen not to see her patients as brains on sticks, but to engage with the social life of the brain and the person with a compromised brain. For this, I have no doubt at all, and we've seen some evidence of this today, that all the adolescents and other people that Jackie cares for are grateful. And I have no doubt that we should all be grateful too. I'm sure we all are. There's a second issue about care though, and how Jackie's work is important in terms of care. As scientists and practitioners working under very stressful circumstances, and many of you have worked under circumstances which it just astonishes me how you've managed, and especially under these pandemic conditions, when science at the same time and expertise are under brutal and dangerous attack. We all need to think about what needs to be done, not only to do the work, but to sustain the work, to deepen the work. We need the science in its narrow sense, there's no question about that. But we also need to do the work, the hard work, in order to keep that work going. In the ethics of care literature, care is defined very broadly as what we need to do in order to sustain our world and to keep it generative and alive. And this goes from the individual, from their brain, right through to our planet. There are so many people in this room and further afield who know what Jackie has done and is doing partly through this very talk today, to keep the excellent services of this hospital and this university going. I have seen some of the astonishing positive feedback she has received across the board, and this is all well deserved. Thank you, Jackie, for not only telling us about this, but also very crucially for showing us through your actions that science is good, but science with care is essential. Finally, I think we need something which is actually much more difficult to define. I'm tempted to call this quality agility, and I'm aware that this links with the grit and grin that Dan was talking about. But I think it's something more than this, because it encompasses not only the ability to change and to move quickly as the situation changes, but also, and I think this is fundamental, to have the patience and the commitment to put in the long hours of slow work, building up a profile and building up stamina which enables agility to occur, and at that time for the agility to look effortless. One thing Jackie has not really spoken about in detail is her long years of building a consultation liaison service. She has worked hard to break down the barriers between mental health care and physical care. Now, these barriers are unfortunately, and how ironically, co-constructed from both sides. So we're all very good at building these barriers. We all like walls to make us safe, and we all, just as countries in the north are doing at the moment, use our constructed walls as a way to throw our rubbish out into the property of the other. For the technically minded here, you'll recognize that I'm talking about projective identification. For the long haul, Jackie, to use a cliche, has built bridges rather than walls. Her work has made it much more difficult for those outside of mental health to depict mental health as academically inferior, as a weak field, not based on evidence, ephemeral, hocus pocus, and useless, terms that I've heard many times. But she's also made it much more difficult for those of us in mental health care, and I'm definitely a guilty party here. She's made it much more difficult for us to stereotype our colleagues as constitutionally and characterologically out of touch with patient emotions and their true needs, as technicians rather than true healers. The work that Jackie has done over many years to work together with others in an atmosphere of mutual equality and respect is, I believe, foundational to what she and Louise Frankel are suggesting can and should be a core part of consultation liaison psychiatry. In fact, consultation liaison psychiatry at its best. This is a shift, and it's a radical shift, is towards a politics less of psychopathology in its narrow sense than of solidarity in its inclusiveness. Jackie, I'm not the only one by any means to suggest that you have done something remarkable during the pandemic, and very, very quickly. But you've done it by building on long, slow, careful, and often quite invisible work, and I think underappreciated sometimes. This is something that we all need to learn from. You show us that care, like science, is a long haul. On a personal note, I want to acknowledge how incredibly lucky I am to have Jackie as a friend. You and Doug and Arwen and all your many animals, including the chickens, have done and continue to do so much to support, enliven, entertain Louise and me. Thank you. You have given this remarkable time at a difficult time for you and your family, and I hope that we can support you as you all support us. But the main thing that I want to say here in conclusion, and you'll all be relieved that the conclusion is coming, is that it is no denial of the reality of pain, something which you spoke about so eloquently, Jackie, to say that we've got good reason here to celebrate. We celebrate, Jackie, not only what you have done and your achievements, but also what these mean for many people, for patients, for colleagues, and for many people, not only here, but globally. You really are working for better mental health for all, which means a better world for all. Thank you, Jackie.
Wow, what an amazing inaugural lecture. As you can imagine, I host many inaugural lectures, and I've been doing this since I became DVC back in 2012. So I've seen many inaugural lectures, hosted many, and this has been the most special I have ever been in. And it's really, really thank you to you, Jackie, not only for what you've presented today, but for who you are, the work that you do, and how you do it. Thank you. We are very fortunate as UCT that you chose us. You could have chosen another institution anywhere in the world. And so I have to say thank you for choosing us, because not only of what you do, who you are, an incredible scholar, a good friend. I mean, I have to say thank you to Dan for that amazing introduction of you that gave us a sense of how people actually experience you. As Dan was speaking, I was looking at Les, hoping that Les will look at me, and I thought I'd say to Les, we need Professor Fixit at our exec meetings, don't you think, Sue? But thank you so much, Dan, for that introduction. Very thoughtful, very touching, and everything beautiful that Jackie is. Thank you very much, Professor Swartz. We are fortunate to have Jackie in our midst, but that you are there as a friend, because as I say, we benefit from what people become. And many of us who benefit from what people become and people are not in the journey of making them become. We benefit from their becoming, and their becoming is influenced by the people who are around them. So everyone who's here, Jackie's family and friends, thank you for the support that you've granted Jackie. It's been an amazing time today, and I'm glad that the executive staged a takeover of the Faculty of Health Sciences inaugural lecture. And so thank you very much, Lina, and the team in Faculty of Health Sciences. Jackie, on behalf of Council, Senate, and everyone in the UCT community, congratulations on your your promotion to professorship, and we wish you everything of the best. Continue to do you, because it is in you being you that we benefit immensely, not only as an institution and Groteskil, but as a country, as a nation, as a people. Thank you. We need more of you.